Hello and happy Thanksgiving. This is the Edina November 2024 review. There's two cases that we talked about and then a couple other points that we discussed this last month. The first was a 65-year-old guy with a traumatic arrest. Medics found him on scene outside an apartment building on a cold day last February. He was cold, but people that the caller, the reporting party, had said that there were signs of life, that they had seen him roll over. So very recently to when the medics arrived, the guy apparently had been alive. There was some blood around him, but not very much, which seemed a little unusual. He had some cuts on his wrists. So looking at a combination of a traumatic arrest, suspicious looking circumstances, and being a little bit hypothermic. And a couple things we talked about. One, the default is to start resuscitation. If there had been absolutely no signs of life and clearly the guy was deceased, that would be different. But in somebody who he was alive just not very long ago, then our default should be aggressive. And I think that's a good call just generally. We should show up wanting to assume that we're going to start resuscitation, not assuming that we can stop or not start, I should say. So related to that, if you do show up on scene with someone and you realize you can't start resuscitation, perhaps somebody who has been somebody who's found down outside and is completely frozen. Important things to document that you can't start resuscitation, and things that would limit you from actually starting resuscitation are a frozen chest where CPR is not going to be effective, ice or snow packed in the airway that you can't get any kind of airway at all, or obviously signs of just obvious signs of like they're really dead. Predation, I think, is one probably in the guidelines written somewhere, but like clearly dead. Just make sure you document that well for the good of everyone involved. So we know, yep, we wanted to, but there's just no way that we can actually start. So it's important to document that. So on this one, we talked about him being hypothermic and how that's not a typical cardiac arrest. We don't work it quite the same. The literature would say that we don't really need to push medications and do lots of shocks because they're just not going to work. Is there a downside of pushing medications? I don't know that there is a huge downside to pushing medications. But if you get through 3-4 shocks and maybe even a couple shocks and it's not working, you probably just want to focus on the good CPR and get them to the ER so they can get warmed up a lot faster. So those are the main things with this guy. He went to Southdale. His hemoglobin, I guess a follow-up on this, his hemoglobin was 8, and interestingly enough, it looked like it would have been lower because it looked like he had completely bled out, but maybe that was a combination of bleeding out a decent amount and the cold. I'm not entirely sure there. They tried to warm him up for quite a while. They had actually called for ECMO, and ECMO declined to warm him up, probably just with the totality of circumstances. They didn't think it would be useful. So they tried for quite a while, but then he ultimately was deceased. So the other case we talked about was, I think, also similarly aged 65-year-old guy who initially thought that he got hit while he was on a scooter. Turns out he had tipped the scooter over and then got run over by an SUV. He had lots of trauma. He's still awake and talking. The important ones in this one is that they tried to look for sliding signs with the ultrasound and had trouble seeing. And the main reason because there was air in his chest. And then he had some very strange swelling over his clavicle. And again, that was all subcutaneous air. And it sounds like it didn't crunch and crackle like subcutaneous air often does, but the ultrasound was very hard to see. And that should be a key when you're looking with ultrasound. If you can't see something like that, and you can't get a view, be suspicious for subcutaneous air, because sometimes it's not always obvious, but the ultrasound won't shoot through subcutaneous air. So medics did a good job. They did a spear in the chest, I believe in his right chest, and talking with my colleagues at Hennepin later, that they no doubt saved this guy's life. He had a huge air leak, had a right mainstem bronchus tear, which took a couple of chest tubes. He ended up with getting, I believe, 2 chest tubes on each side. So they did a good job. Short scene time. I don't think they gave TXA, but we discussed TXA, and certainly you could in this case. And a guy with big trauma like that, you can assume he's probably bleeding somewhere. I believe he had a retroperitoneal bleed, and I don't know the size of that. But you can assume a guy who gets hit by a car and has some big trauma is probably bleeding somewhere. So TXA would certainly be reasonable. And again, all those things, a lot of those things, doing them en route, not staying on scene to do the ultrasound, not staying on scene to do the TXA, like get the patient loaded up, get some IVs going, and get down the road. I think both these cases were handled well. A couple other comments about ultrasound in general. Again, I think the value is the binary feature of it. So like either this thing is there or it's not there. With sliding signs, either they're sliding or they're not sliding. If there's B lines, if somebody's got pulmonary edema, either they're there or they're not there. When you look for a AAA, we discussed aortic dissection and AAA. Aortic dissection is harder to see with ultrasound. If you see it, you can say that it's there, but if you don't see it, you can't say it's not there because it's not that good of a test. You need a CT scan to look for an aortic dissection to really confirm that it's not there. Abdominal AAA, on the other hand, you should be able to see. That should be very obvious in the abdomen and the right clinical context. There's either a huge aorta with a bunch of clot in it, or it's a normal sized aorta. So again, it should be a fairly quick look. It's either there or it's not there. If you're taking forever to look around and you're like, oh, that maybe that's the aorta and it seemed normal, that's not the problem. So it should be very quick. And again, the binary features of ultrasound are what I think makes it valuable. And again, it limits the time that you're having to use it. In a cardiac arrest, either the heart's beating or it's not beating. Is there free fluid or is there not free fluid? They're meant to be yes, no questions and answered fairly quickly and not spend a ton of time on that. So lastly, there was a question came up about a patient who needed dialysis. Sometimes they get kicked out of they're on Pleasant and they get kicked out of wherever they're getting dialysis. Or for whatever reason, I've had patients like who get bed bugs and then can't go back to their dialysis center for whatever reason, and then they need to go to an ER somewhere. To my knowledge, there's not actually an ER in the metro that has the capability to do dialysis. It has to do with the water supply. I know for sure Hennepin does not have this because it came up some years ago, but they don't have like the purified water supply lines that they need, like on a dialysis unit. However, I imagine most hospitals do have some place to dialyze patients. It's just not going to be in the ER, and whether they can work that out with their nephrology colleagues is another question. So that becomes a system issue that's not yours to worry about. But just know if you get pushback from somebody say, hey, the ER can't do dialysis, yes, that's probably true. I don't think any ER can, but the hospital should have some way to dialyze patients. The ICUs certainly have ways to dialyze patients. They probably have some other beds to dialyze patients, and that's a system problem. But no, the ER probably does not actually have dialysis. So that's all I got today. Happy Thanksgiving.